This is Dr. Goodin with Somatoform and Dissociative Disorders. Welcome back. With regard to somatoform disorders, they're a group of conditions that involve physical symptoms and complaints, suggesting the presence of a medical condition, but without any evidence of physical pathology to account for them. So there's a preoccupation in each case with some aspect of health or appearance to the extent that the patient has significant impairments in functioning. Dissociative disorders are a group of conditions involving disruptions in a person's normally integrated functions of consciousness, memory, identity, or perception. They cannot recall who they are or where they may have come from. People who have two or more distinct identities or personality states that alternately take control of the individual's behavior. If you've seen the United States of Terror, that's what we're dealing with, and we'll get further into this dissociative identity disorder here in a few slides. Dissociation refers to the human mind's capacity to engage in complex mental activity in channels split off from or independent of consciousness awareness. Soma, the word soma means body. Somatoform disorders involve patterns in which individuals complain of bodily symptoms or defects that suggest the presence of medical problems, but for which no organic basis can be found that satisfactorily explains the symptoms, such as paralysis, pain, whatever it may be. They tend to see many doctors searching for a diagnosis when there truly isn't one, not a physical diagnosis. These individuals are typically preoccupied with their state of health and with various presumed disorders or disease of bodily organs. There's no control over their symptoms. They're not doing it on purpose normally. We'll get into that here in just a moment. As I said, lots of doctor's visits and many misdiagnoses. One of the problems with your basic medical doctor, your family physician, is often psychiatry and psychology are not major emphases historically in most medical specialties. And so you go to a lot of doctors and they're unable to recognize when you actually have a psychological issue or a neurological issue. And instead they keep trying to figure out why your arm isn't working properly. Well, that could be a conversion disorder, but normally they call the psychiatrist in after they've tried everything else, run all the tests, all that sort of thing. Eventually somebody will say, well, let's call the psychiatrist, and psychiatrists will come over, consult, and often be the one who figures out what's really going on. So they're not intentionally faking symptoms or attempting to deceive others. If they were, you might have two specifiers: malingering or factitious disorder. Malingering means they're intentionally producing or grossly exaggerating physical symptoms and is motivated by external incentives such as avoiding work or military service or evading criminal prosecution. Factitious disorder is when a person also intentionally produces psychological or physical symptoms, or both, but there are no external incentives. The person's goal is simply to obtain and maintain the personal benefits that playing the sick role may provide, including the attention and concern of family and medical personnel. There are 5 main types of somatoform disorder, and here, of course, I have a picture from Black Swan. If you haven't seen it, it's not family friendly, but it does show you some of this. It does cover some of this type of content. But the 5 main types are hypochondriasis, somatization disorder, pain disorder, conversion disorder, and body dysmorphic disorder, which we'll go over one at a time. So hypochondriasis um, is a preoccupation either with fears of contracting a serious disease or with the idea that a person actually has such a disease even though they do not. They have distressing preoccupations based on misinterpretation of one or more bodily signs or symptoms. So they get a slight cough, they conclude that they have lung cancer. The person is not reassured by the results of a thorough medical evaluation. The fear persists despite a clean bill of health, despite medical reassurance. Fantastic doctors saying nothing is wrong with you. They're actually disappointed when no physical cause is found. This normally lasts 6 months or more, and during that time they're preoccupied with bodily functions. So they're very attuned and hypervigilant towards what their body is doing, their heartbeat. How many of us slow down and pay attention to our heartbeat each day? Their bowel movements. Hopefully you're not paying too much attention to that unless there's truly something wrong with it. These things, if you concentrate on a part of your body long enough, you'll realize that, oh, my throat's a little dry. Man, no, it feels a little scratchy. And then next thing you know, you're worried that you have, a sinus infection or, some sort of cold. Also focus on minor physical abnormalities, a small sore, an occasional cough. Meaning people with hypochondriasis, attribute these to a disease and have intrusive thoughts about it. They often self-diagnose extravagantly that they have AIDS or cancer. It's normally not a simple diagnosis of may have a slight cough or the cold. It's normally something major. You see that anxiety is playing a role here, so pay attention to that as I continue talking. Causes are unknown but seems to be related to anxiety. Some call it health anxiety. Most believe it is a disorder of cognition and perception. This is, of course, the cognitive perspective on things. And they have these faulty, dysfunctional assumptions, like that bodily change equals disease. There's an attentional bias. In other words, they pay attention to the things that support their viewpoint. There's an intentional bias for illness-related information. Once they have misinterpreted a symptom, they look for confirming evidence and discounted evidence to the contrary. They believe that being healthy means being completely symptom-free. Okay? For them, being healthy means completely symptom-free. Now just think about this. A lot of you may have had this, but gotten a little, heartburn. You get heartburn? These people absolutely would never say, that's heartburn. No, for them, it's a heart attack. It's a heart problem. They're going to die. Now, how many of us get a little scared when we have heartburn or something like that? I think a lot of us. It's occasional, or when our anxiety's high and we feel heavy-chested. But these people are going to very quickly move to the idea that they have a heart issue that is going to kill them. Once they have misinterpreted a symptom, again, they're going to search for confirming evidence. They're going to discount any evidence to the contrary. They also perceive their ability to cope with the potential illness as low, so they're extremely fearful. They see themselves as weak and unable to tolerate physical effort or exercise. Sometimes these individuals have had a sickly childhood or lots of family illness that may be playing a role in their disorder. Treatment is normally cognitive behavioral therapy, CBT, and they often have patients induce innocuous symptoms purposefully. I want you to cough for me. I want you to pretend you have a cold. They're also ordered to not check their bodies or seek reassurance. I don't want you to look in the mirror all day. I don't want you to, check that mole on your leg. It's already been checked out. Your goal for the day, your homework is go home and, not check your body. There's a new mole. You get extra points if you don't pay attention to it. They're also treated with SSRIs. So let's see. Somatization disorder is characterized by many different complaints of physical ailments over at least several years, beginning before age 30, that are not adequately explained by independent findings of physical illness or injury, and that lead to medical treatment or to significant life impairment. Lead to very costly health treatments because you're seeing so many doctors. Same with hypochondriasis. And all these are very similar. That's why they're in the same category. Now, some are a little more physical, have more of a physical relationship. You'll notice those, and then we get into more of the dissociative, which is more of a cognitive issue from my perspective. If we got into criteria, notice everybody. Please notice that I am not. Here and there, I'll cut and paste a DSM-5 criteria for a disorder, and I'll put it on the slide. But notice that I'm not, at least not all the time. That's something I don't expect you to memorize most of that. And especially if I don't put it on the slide, it is not, unless I tell you otherwise, it will not be something I'll test you on. So let's go with what I do test you on, or what I do talk about will be the things that are possibly going to be on the test. This is something that you don't have to necessarily memorize, but criteria, for instance, for a somatization disorder would be like 4 pain symptoms, 2 GI or gastrointestinal symptoms, 1 sexual symptom, 1 pseudo-neurological symptom, such as loss of sensation, involuntary muscle contractions. These people are not as convinced that their issues are actually organic. So hypochondriasis, they are sure it's something physical, and they get disappointed when there's not a physical finding, a physical problem that the doctors find. These people with somatization disorder are not as convinced it's organic, and so are going to be less disappointed. I mean, of course, everybody wants to find out what's wrong, but they're not as sure that it's a true something wrong with their body. This is 3 times more common in women than in men. Unfortunately, there's a poor prognosis, which means poor outlook for these people. They're unlikely to be, quote, healed or to recover from this disorder. It's likely to be a lifetime issue. Genetic and familial linkage, it leads to antisocial personality disorder in men, but somatization disorder in women. So depending on your gender, some of your genetic flaws or combinations may result in different things. Again, APD in men, somatization disorder in women. This is known for high neuroticism. Sensations equals symptoms. These people often catastrophize minor bodily complaints and this is all similar to hypochondriasis. Again, CBT, or cognitive behavioral therapy, is used, as is medical treatment, wherein a doctor has consistently scheduled visits with limited testing and accepts the bodily complaints as valid. I understand that you're feeling this way. I understand that you have pain in your chest. So they don't necessarily fight them on that. One thing it does is give them the attention they want, and then subdue it by saying again and again, here are the findings. But CBT is tough for them. Again, poor prognosis. Pain disorder is a very similar thing, but we're focusing on some sort of pain. Not just a random illness, but just pain in specific parts of the body or all over, like somatization disorder, but without the other symptoms. It's characterized by the experience of persistent and severe pain in one or more areas of the body that is not intentionally produced or feigned. They do not do this on purpose. Medical conditions may play a role. Okay, there may actually be some medical condition at play, but psychological factors exacerbate the issue. And the pain is real. It does actually hurt in the mind and the receptors of this person. The pain, the subjective pain, is real, and it's not useful for a doctor to say the pain you're feeling is made up. Pain is subjective. It can't be proven or disproven. You can't tell me what I'm feeling inside my body. Now, you may be able to tell me you can't find a physical cause for it. These people may become disabled. Pain may increase when others give attention, sympathy, or they may avoid unwanted activities, and that may also lead to even more pain. So it's kind of like the more you feed it, the more it grows, sort of thing. Now, I want to make an important distinction here. I was talking earlier about the psychiatrist who is called after all the doctors have run all the other tests. That's my father. He was a psychiatrist. And the short story on my father, who I'm very proud of, he was a great physician. But the short story with him is probably due to overwork, maybe some genetic influence. I'm not exactly sure because it's not well known, but he has what's called fibromyalgia and chronic fatigue. What we see here is CFIDS is a common label for that sort of thing. It involves immense pain throughout the body. These people are normally, as my father is, disabled, and the doctors can't find. There is definitely some physical evidence, but the doctors don't know really what's going on exactly. It's sort of a disease that they don't know how to fix, sort of like there's no cure for cancer yet, but they know a lot more about cancer than fibromyalgia. But a lot of doctors traditionally have not believed in CFIDS. So my point is that I have some knowledge of CFIDS. This is not the same as chronic fatigue immunodeficiency syndrome, which is real, but not understood as is fibromyalgia. However, CFIDS and these other types of diseases like it are not given sufficient credibility at present, among some doctors at least. But it's not the same. Pain disorder is all in the mind. CFIDS has some physiological impairment at play. They just don't know how it's actually causing problems. Treatment is normally with CBT and or SSRIs. Conversion disorder involves a pattern in which symptoms, and by the way, before I move on, if you haven't taken a break yet, remember, take breaks every 15 minutes. Go use the restroom, get a drink of water, rest your hand from taking notes. It's not good. You're going to quit capturing information if you don't take a break. If you're familiar with it, think about the primacy and recency effect. It's good to create several starts and stops as you're learning. So take a break, pause me, start again. I'm not saying you wait a week and then start again, but take 5 minutes, take 15 minutes. Okay. Conversion disorder involves a pattern in which symptoms or deficits affecting sensory or voluntary motor functions lead one to think a patient has a medical or neurological condition, but medical examination shows that the pattern of symptoms cannot be fully explained by any known medical condition. This is called a conversion disorder. Examples can be partial paralysis, blindness, deafness, pseudo-seizures. Psychological foundations based on symptoms starting or being exacerbated by preceding emotional or interpersonal conflicts or stressors. So there can be some psychological issues at play that lead to this or exacerbate this. Freud called it conversion hysteria, and he was thinking about sexually repressed urges that are threatened to become conscious. They're threatening to become conscious, so instead the body converts them into a bodily disturbance. So especially if you're in a more of a strict religious setting where masturbation is considered wrong, the wish to masturbate might result in a paralyzed hand. Of course, the idea is not that God is doing that to you, but you're doing it to yourself out of guilt. You're converting the unconscious that is threatening to become conscious. You're converting it into a bodily symptom in order to subdue it or suppress it. So modernists say that traumatic history may play a role. A person seeks to escape an intolerably stressful or uncomfortable situation in which there may be no actual escape, so conversion takes place. This is not on purpose. These people are not acting. They truly just don't know what's wrong. And again, this is something that a lot of doctors will look at, and then eventually a psychiatrist or neurologist will be brought in, and we'll be able to see it for what it is. Let's talk about primary and secondary gain. Primary gain is continued escape or avoidance of stressful situations. Symptoms dissipate if the stressor is removed or resolved. There's also what's called a secondary gain, where attention from loved ones or financial compensation sort of reward the psychological issue. There's decreasing prevalence due to growing sophistication about medical and psychological disorders. Okay, so these conversion disorders are happening less and less because we as a society, hypothetically, according to the book, we're becoming more intelligent, or at least more sophisticated about medical and psychological disorders. Conversion disorder loses defensive function if it can be readily shown to lack an organic basis. Okay, so it's only useful until we become knowledgeable. It's common among rural and lower SES, unfortunately lower intelligence individuals, the medically unsophisticated, we could call them. It's 2 to 10 times more common in women. I'm not saying that's because they're less medically sophisticated. Why would you think that that women would have more of this? There's my thoughts on it, 2 cents, maybe worth more than that, but is that, of course, there's more of a bodily focus on women, their appearance, their shape, um, right, all of these things. And so there's got to be more attention paid to their bodies, more looking in the mirror, um, more grooming, self-grooming, and these sorts of things. So they're going to be more in touch with um, what is truly wrong and what could possibly be wrong. Okay, and they may become a little obsessive about it. Um, it's a big deal for all women, but especially um, I believe could easily become a problem with the amount of attention our society puts on it and the amount of pressure our society puts on it. I I look at this and think that it will increase among males, at least equalize among males because males are becoming increasingly objectified in their physical appearance. Um, it's often precipitated by a life stressor, and there's four categories of symptoms: sensory, motor, seizures, or mixed presentation of the first three: sensory, motor, and seizures. Okay. Sensory, we might think about blindness or tunnel vision. Um, Now, anesthesia and glove anesthesia are interesting. Anesthesia is when a person loses his or her sense of feeling in a part of the body. Glove anesthesia is specific to the hand. It's loss of feeling in the hand. During conversion, blindness, or deafness, it may be that people still receive sensory stimuli unconsciously. They can still hear and move around a room without difficulty. The point is that their complaint makes no anatomical sense. Now, these people are walking around the room telling you they're blind. Of course, they look silly saying that, but that's what they truly believe. Um, Motor symptoms or deficits, conversion paralysis in a single limb, an arm, a leg, um, is pretty common. Speech-related conversion disturbance is called aphonia. That's the most common, in which a person is able to talk only in a whisper, although he or she can usually cough in a normal manner. That's called aphonia. And then there's globus hystericus, Globus hystericus. This is difficulty swallowing. Globus hystericus. It's probably the correct pronunciation, I'm sorry. Difficulty swallowing or the sensation of a lump in the throat. Seizures, or normally in this case they're going to be pseudo-seizures, which resemble epileptic seizures in some way, but can usually be fairly well differentiated through medical examination. On an EEG, there would be no abnormalities. Other common criteria are inappropriate appearance of a disorder. In other words, you have a disorder, but it's not showing up the way it normally does in other people. Or you say you have a disorder, but it doesn't show up properly. Selective in terms of useful and careful nature of the dysfunction. It's useful in some way, like to get welfare checks or to avoid doing something you don't like doing. Symptoms disappear during hypnosis or upon sudden awakening, right when you wake up or when you're under hypnosis. When you're sort of in a subconscious state, you're not going to have your issues anymore. Conversion disorder treatment is often with behavioral training. And here we see, different gaits that some people might have with some of these somatization disorders, conversion disorder. Body dysmorphic disorder. Now we're getting into, and I will cover this more, eating disorders and things like that, appearance and eating disorders. This is definitely leading into that. Body dysmorphic disorder, identified as a somatoform disorder because of a preoccupation with certain aspects of the body. It's called BDD. It's obsession with some perceived or imagined flaw or flaws in appearance to the point that a person believes that they are disfigured or ugly. It causes clinically significant distress and or impairment in social or occupational functioning. Most have compulsive checking behaviors, checking in the mirror, looking at eyebrows, picking at oneself, picking at moles, um, picking at hair follicles, pulling hairs out, maybe to a small degree. They often avoid normal activities due to not wanting to be seen. They don't want to repulse others, and they truly believe that they will repulse others. The employment rate for these individuals with BDD is 50%. So they are avoiding activities, things they need to do. They stay home. They're really scared of being seen and hated and grossing people out. They see themselves not just as overweight, but as ugly and gross to look at. As in, it's going to cause other people to vomit if they look at me. Something as drastic as that. And they truly believe it. It can be any body part: skin, breasts, face, blood vessels, hair, nose, eyes, stomach, and some have multiple body parts that they focus on. They may have actual small defects that are exaggerated and causes extreme discomfort. They do seek reassurance, but it only gives them temporary relief. Some self-check for reassurance. Mirrors and scales are really common, while some others avoid mirrors altogether in the hope that they will look different. They usually feel worse. They have excessive grooming behaviors to camouflage their defect. So, you got a tiny mole on your, face. You're very likely to spend a good deal of time, putting a lot of makeup over it. You don't like the way your hair looks, you're going to wear a hat or something, or a wig even. But just know that the lengths that these individuals will go to are extreme. Okay. Gender differences are based mainly on societal expectations. So if you're obviously a female, you may worry about your breasts more. That's not really a male issue. Males might worry about their penis size, things like that. BDD is often comorbid with depression and suicide, at least suicide ideation, if not attempt. 75% of these individuals seek non-psychiatric help. Doctors often take their money over and over again. Plastic surgeons make a lot of money off these individuals. Look at some of our famous Hollywood stars, rock stars. Michael Jackson, for instance, would have loved to have been his plastic surgeon. Would have felt bad about it, but obviously these surgeons, there are plenty of plastic surgeons that don't feel bad about taking your money. It's influenced by cultural expectations of appearance. That kind of goes along with what I said about gender. It's difficult to study due to avoidance and secrecy and the shame that these individuals feel. So they really don't want to talk about what's going on with them. They don't want you to look at them. So they're hard to get to in terms of doing research on their illness. High neuroticism among these people. Very negative self-schemas. If my appearance is defective, I am worthless, is what they would say. It's often reinforced as children for, they are often reinforced by society or their parents. They're reinforced for their appearance instead of their behavior. Well, you're so pretty, instead of, oh, you you're really good at math. So excessive focus on appearance, um, not only bad because we all get old and wrinkly eventually, but um, that's one thing our society does is unfortunately it grades us on criteria that we actually cannot change to a large extent. I can work harder in math. I cannot um, change the color of my eyes, for instance. Um, and when you start to try to change some of these things, as I said, it gets really expensive. 56 to 68%, that means different studies have found different percentages, have experienced emotional neglect or abuse. 30% have experienced sexual abuse or physical neglect. Treatment is often with CBT and SSRIs. So, dissociative disorders involve disruptions in certain aspects of the person's consciousness, memory, identity, or perception. Dissociation refers to the human mind's capacity to mediate complex mental activity in channels split off from or independent of conscious awareness. Mild dissociation is common. Daydreaming, automaticity, which is when you drove to work or you drove to class today and you don't remember the trip, just you kind of dissociated, maybe you thought about other things instead of your driving. Just zoning out is a mild dissociation. Implicit memory refers to all persons routinely show indirect evidence of remembering things they cannot consciously recall. Implicit perception is responding to sights or sounds as if a person had perceived them, as in conversion blindness or deafness, even though they cannot report that they have seen or heard them. In dissociative identity disorder, ongoing mental activity outside of awareness appears to be subverted, sometimes for the purpose of managing severe psychological threat. Okay, and we're going to get a little more into this. In other words, if there's danger in your life, sexual abuse, physical abuse, things like that, a split or an alter ego may be useful. It may be useful to dissociate in order to keep the psyche from being overwhelmed by trauma. Okay. Like somatoform disorders, dissociative disorders appear mainly to be ways of avoiding anxiety and stress and of managing life problems that threaten to overwhelm the person's usual coping resources. Both types of disorders deny personal responsibility for unacceptable wishes or behaviors. In dissociative disorders, the person avoids the stress by pathologically dissociating, in essence by escaping from his or her own autobiographical memory or personal identity. All right, now the picture here is, I should have explained a few more pictures. Jason Bourne obviously had some memory or dissociation issues. This one I think you get. So, what are we dealing with here? Before I get into this slide, I just want to say people with depersonalization disorder are going to feel sort of an out of body experience. They may feel as if these hands are detached, or if their head is actually detached from their body. So we'll get into that. Derealization is one's sense of the reality of the outside world being temporarily lost. Okay. Whereas depersonalization is one's sense of one's own self in one's own reality is temporarily lost. So one, derealization is the outside world, is the reality of it is lost. Depersonalization, your sense of yourself in your own reality is lost. Depersonalization disorder occurs when depersonalization and derealization become persistent and recurrent and interfere with normal functioning. Persistent or recurrent experiences of feeling detached from and like an outside observer of their own bodies and mental processes. The changed condition is perceived as unreal and discontinuous with previous ego states. The object of the experience, self, which would be depersonalization, or world, which would be derealization, is commonly described as isolated, lifeless, strange, and unfamiliar. Self and others are perceived as robots, automatons, behaving mechanically without initiative or self-control. You might feel as if the world was mechanized, or somebody was pulling strings on puppets. You as a puppet, or things around you as puppets. They often report feeling that they are living in a dream or a movie, some alternate reality. Research shows lower emotional arousal during depersonalization. Oh, here's a clip from
Here we see a picture from Memento.
a movie. Anybody know that movie?
And we get into retrograde and anterograde
Movie
amnesia. Retrograde amnesia is the partial or total inability to recall or identify previously acquired information or past experiences. What do you think anterograde is? The partial or total inability to retain new information. So think about the movie 50 First Dates, if you want to. You don't have to. But that would be more anterograde. And as would this movie, Memento. Dissociative amnesia is limited to a failure to recall previously stored personal information beyond what would normally be forgotten. Okay, it's not a normal amount of forgetting. And it's personal information, which makes it dissociative. It's often during intolerable stress, circumstances such as combat situations, car accidents, violent situations. All information can be remembered under hypnosis. That's how we test a lot of these things, is what can be remembered under hypnosis, and that's one way we can tell whether things are actually completely lost or not. Hypnosis is like checking the black box and seeing what is really happening. Of course, when hypnosis ends, the person goes back to forgetting again. One type is localized amnesia, no memory of a specific period, usually after a trauma. Another type is selective amnesia. A person forgets some but not all of what happened during a given period. You may want to just forget that so-and-so was there. An ex-girlfriend or somebody you don't like, I don't know. Or you want to remember it a little bit differently. These are... One thing about psychology, you need to remember everything does serve a purpose. Even if it's not conscious, it's still maybe your subconscious doing something on your behalf to block something out that you really don't want to think about. Amnesic episodes can last a few days or a few years. Basic habit patterns remain intact, like your ability to talk, things like that. Episodic memory disappears, but semantic, procedural, and short-term memory, sorry, I left out procedural. You may want to note that. Episodic, semantic, and procedural, and short-term memory all remain intact. It's, episodic disappears. Semantic, procedural, and short-term remain. Okay? So just make a note of that. Episodic stays, semantic, I keep getting it wrong. Episodic disappears. This one, circle it and put an X through it. It disappears. Semantic, write in procedural, and short-term memory, or working memory as you may know it, they all remain intact. Okay? You can circle them and not put an X through it. I'm sorry about that. Okay. Dissociative fugue. The word fugue means flight. This is a more severe amnesic state, just basically because of the damage it can do. A defense by actual flight or leaving physically from a location, in addition to amnesia for some or all aspects of a person's past. There's confusion about personal identity and sometimes the assumption of a new identity. They do not alter between identities as they do in dissociative identity disorder. They don't go back and forth. They assume the new identity if they take one on, and may not, quote, wake up from that for quite some time. Unaware of their memory loss for their previous identity or, quote, previous life. But they do have memory for fugue state. So during this fugue state, whatever memories whatever happens, they can remember during that time. So their memory works properly within that fugue state. Normal behaviors during the fugue state, but different than what may have been their previous normal lifestyle. So within the fugue state, they develop a normal pattern, a new lifestyle, a new identity. And that becomes the norm, but that norm may be different than their previous norm. They sometimes find themselves, when the fugue state ends, they may, say, where am I? What am I doing here married to this person doing this job? Or somebody else, a family member, may find them in a new city with a new occupation. Again, another way to escape from unpleasant situations that they cannot escape. Implicit memory remains intact. Okay, DID, or Dissociative Identity Disorder. Here's a picture from Fight Club. Multiple personality. If you haven't seen it, again, it's not a family-friendly movie, but it's a dramatic dissociative disorder in which a patient manifests two or more, a few of these concepts, often 10 or more. That's all I'll say. At least two or more distinct identities that alternate. So, in some way, it was formerly called multiple personality disorder, or unable to recall important dramatic dissociative disorder in which a patient manifests two or more distinct identities that alternate. In some way, each identity has a different personal history, self-image, and name. Unable to recall important. So the host identity is the identity that is most frequently encountered and carries the person's real name, self-image, usually in name. Then there's the post identity. Not the original identity. Not post. Host identity. Alter identity. Host identity may differ in gender, age, wrong here too. Left or right-handedness, handwriting, sexual orientation, prescription for eyeglasses, mood, host identity, foreign languages spoken, and general knowledge. Needs and behavior are inhibited in the primary or host identity, and are usually liberally displayed by one or more alter identities. A child identity is often common. An opposite sex identity is common. Note that multiple personality disorder was dismissed as being a misleading name. There is no multiple occupancy of space. Alter identities reflect failure to integrate various aspects of a person's identity, consciousness, and memory. The alter's identities take control at different points in time. Switches typically occur in seconds, but can be gradual. People with this will often have gaps in memory for events experienced by the other identities. Some identities know more about the alters than other identities. It's quite possible and common that one identity will know what's going on, know about the other identities, whereas there can be some identities that are sort of in the dark and unaware that that another identity is even present. Submerged identity can gain control by producing hallucinations, like a voice inside the head giving instructions. So DID is a condition in which normally integrated aspects of memory, identity, and consciousness are no longer integrated. Onset is usually in childhood. Females are known to have more alters, possibly due to more childhood sexual abuse of females. Social and media factors, such as a therapist's misguidance, seem to influence the increase in number of alter identities. 50% of people with DID have over 10 identities. It's sometimes overdiagnosed in lieu of moods and mood swings. Some examples are the movies Sybil, the show United States of Terror. Interpersonality, amnesia is Alter 2 cannot remember something that Alter 1 learned, a word sequence, for instance. However, Alter 2 can learn the sequence more quickly than normal. Okay, this implies that there is implicit memory, that it has actually been learned, and to some extent the information is shared between identities, but not consciously. Another thing that's interesting is that the different identities have different EEG patterns. Of course, there's controversy surrounding this disorder. Is it real? How does it develop? Are abuse memories real? Did abuse cause DID? But please note that DID can also be faked. I'm trying to think of a movie. It has Edward Norton in it. Apparently he likes these sorts of movies. He likes playing multiple roles. Can't think of it right now. Something carnal something. It's pretty good. Richard Gere, Edward Norton. Look it up. Let's see. Where was I? So, post-traumatic theory, that's where I was. DID starts from the child's attempt to cope with an overwhelming sense of hopelessness and powerlessness in the face of repeated traumatic abuse. Now, this is one theory for why DID would occur. Lacking other resources or routes of escape, the child may dissociate and escape into a fantasy, becoming someone else through a process like self-hypnosis. If it helps alleviate some pain caused by the abuse, it is reinforced naturally and will reoccur. Sometimes the child simply imagines the abuse is happening to someone else. Then there's fantasy proneness. It also seems to influence DID development, but the diathesis stress model is appropriately explanatory, especially for those without fantasy proneness. DID seems to be associated to some degree with PTSD. There's often a comorbidity. Now we're moving on to the last one here, sociocognitive theory. DID develops when a highly suggestible person learns to adopt and enact the roles of multiple identities, mostly because clinicians have inadvertently suggested, legitimized, and reinforced them, and because these different identities are geared to the individual goals. This is not done intentionally or consciously. Recovered memories may not always be true. As some of you have learned in other classes, it can be influenced by therapist suggestion, can ruin lives and families, accusing dad of molestation when no molestation actually occurred. Um, Childhood abuse may play a non-specific role for many disorders, with other more specific factors determining which specific disorder develops. Moving on to rave parties. Trance issues. No, it's not about rave parties necessarily. Trance is said to occur when someone experiences a temporary marked alteration in state of consciousness or identity, but with no replacement by an alternate identity. You see how this is related, but similar to a fugue state, there's no alternate identity that takes its place. Similar but different. You basically go to a different identity for a short period of time, much shorter than a fugue state. Usually associated with either a narrowing of awareness. Again, this isn't considered really a new identity. It's a trance state, just an altered reality or state of consciousness. Usually associated with either a narrowing of awareness of the immediate surrounding or stereotyped behaviors or movements that are experienced as beyond one's control. Dissociative trance disorder is when a person who voluntarily enters a trance or possession state due to cultural norms often develops distress and impairment with that trance state or within it. You see here, I forget the guy's name, but the actor from the movie called Trance, pretty recent movie. Possession trance is a little bit different. It's like trance, but the alteration of consciousness or identity is replaced by a new identity that is attributed to the influence of a spirit, deity, or other power. Amnesia is typical during trance states. This word AMOK, amok, is a cross-cultural variant on dissociative disorder involving rage, violent, aggressive, or homicidal behaviors directed at other people and objects. This is mostly in men as a result of insult. They go into sort of a trance-like amok state. They're driven by ideas of persecution, anger, and amnesia, followed by exhaustion and depression. Okay, and that's pretty common for any heightened emotional arousal. You're gonna experience a very exhausted phase afterwards. And amok is more common in places like Malaysia, Laos, the Philippines, Papua New Guinea, Puerto Rico, and among the Navajo Indians. Treatments, little is known, but hypnosis is common, as is psychodynamic and insight-oriented therapies, focused on uncovering and working through the trauma and conflicts that lead to the disorder. But it should be noted, this is interesting to me, most DID patients, and you've heard about them, can you be hypnotized? Have you ever been to a comedy hypnotist show? Well, yeah, they tried to hypnotize me. It didn't work. Some of us are more susceptible to hypnosis than others. It's interesting to note that most DID patients are hypnotizable. The goal is to integrate the personalities into one identity that is better able to cope with the current stressors. For treatment to be successful, it must be prolonged, often lasting many years. The more severe the case, the longer the treatment is needed. And, of course, this has implications for ethical and rigorous therapy to be emphasized. Thank you very much. I will see you next time.